Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor, Nick Bostock, to talk about the latest news affecting general practice. Coming up, we're talking about a significant fall in the number of young GP partners, the reason behind this, and what the long-term impact of this workforce shift might be. We're looking at the exodus of UK-trained international medical graduate doctors to other countries and talking about why this group has been particularly hard hit by the GP jobs crisis. We're also talking about new legislation that will prioritise UK-trained doctors for specialty training posts. And we'll be discussing the latest on legal action physician assistants are taking against GP practices, the RCGP and the BMA. Our good news story this week is about the national rollout of the WorkWell scheme, which could help to reduce demand for GP appointments. Managing a practice right now is a balancing act. That's why a team subscription to GP Online is a smart investment. Not only do you get access to GP Online, your team can access MIMS for their prescribing information, MIMS learning to manage their CPD, and GP Business for practice management advice. That means expert advice on red flags, news updates, HR, finance and contracts to keep your practice running smoothly. Support your staff and protect your business. Check out our team subscriptions at GPonline.com. So first up, Nick, let's talk about GP partners. You did a deep dive on the workforce data that we talk about a lot on this podcast, actually, and found that the number of young partners is in freefall. What did the stats actually tell you?
The fact that numbers of GPs in partnership roles overall are in decline is really well known. Just to give a quick sense of the scale of that decline, in 2015, about 3/4 of the fully qualified full-time GP workforce was made up of partners. Whereas in the most recent figures, which are for November last year, November 2025, partners made up just 53% of the full-time equivalent GP workforce. There are about 6,400 fewer full-time equivalent GP partners now than there were in 2015. So 30% reduction. So it's a really steep, significant drop. And I was interested to see what had happened since the last general election in terms of GP partners, just because there's been a lot of talk about the partnership model, particularly in the context of plans for neighbourhoods and concerns about how neighbourhood contracts might interact with the practice level GP contract. And it turned out that England has lost 684 GP partners since the July 2024 general election, which is a 4.3% drop. But then something that stood out was that by far the biggest fall had come among younger GP partners. Partners overall down 4.3%, as I said, but partners aged 30 to 39 are down by 19% over that same period. And that's just, in the 16 months after the general election. Overall, about 3/4 of the total drop in full-time equivalent GP partners since the general election is accounted for by a reduction in partners aged 30 to 44. So there's a really marked slump in younger GP partners, and that has obvious implications for the future, because those younger GPs are precisely the doctors who ought to be the future of the partnership model.
There are lots of reasons why the number of partners are falling, aren't there, which we've talked about on the podcast before, but just explain some of those factors that are particularly impacting on younger GPs.
Some of the factors raised by GPs I spoke to were ones that will be putting off GPs of all ages, not just younger GPs. Uncertainty over NHS policy and funding in the context of the 10-year health plan is a big factor. The government said it isn't planning to scrap the partnership model of general practice, but it has talked about wanting to update it. A lot of questions remain around how neighbourhood contracts could interact with practice level contracts in the coming years, we talked about. And then what will plans for hospital trusts to become integrated health organisations with full control of local health budgets, potentially becoming the commissioner of primary care services in their area? What will that mean? And those are questions all GPs want answers to, but they're likely to be particularly off-putting to a younger GP considering whether to make a massive investment in buying into a practice partnership at the moment. GPs also talked about concerns over workload and risk in partnership. That's also something that's a worry for everyone, but again, perhaps particularly for anyone considering partnership for the first time and whether to go in now. Buying into partnerships is also a lot more expensive than it was in the past because of factors like property prices increasing rapidly. So that's a bigger factor for potential partners now than in the past. There have been some changes to incentives, which we're going to come on to.
Yeah, I think it's also worth thinking about it in the context of wider society and increases in costs anyway, as well, isn't it? House prices have gone through the roof, obviously, over the last couple of decades. And for younger GPs, their priority might be making sure that they've got enough money to buy a house rather than invest into a partnership. So there's those factors that come into play. I mean, the BMA have called for measures to support partners in this year's contract, haven't they? What are they asking for? And how likely do you think it is we'll see any of those in the contract from April?
What the BMA England GP Committee's called for is an incentive programme to encourage GPs to take on and then stay in partnership roles based on a scheme that's been running in Wales for the past few years. The idea is to set up a partnership premium scheme, and that would basically offer any qualified GP in a partnership role in an NHS GP practice an annual payment worth £1,150 per clinical session, up to a maximum of 8 sessions per week. So that's just over £9,000 a year per partner, and the payment would rise to a higher level for GPs with more than 16 years experience, to a level that's worth, basically a maximum of something like £10,500 a year. And the BMA says a scheme like that could help make partnership roles attractive again, could help partners set down roots in communities and rebuild continuity. And it probably would, but I think it's very unlikely to go ahead this year. That's partly because if the government's going to incentivise anything, it seems more likely to be something that's linked to neighbourhoods and setting up neighbourhoods, in the context of the current 10-year health plan, than it is to put money into supporting traditional GP partnership roles, or particularly incentivising GPs to go into or stay in those. And obviously, this is a BMA proposal at a time when the BMA and the government, as we keep on talking about, are not really on speaking terms. And the BMA GP committee have been largely frozen out of the negotiations around next year's contract.
Obviously, one thing we've had recently was the New to Partnership programme. That ended a couple of years ago, didn't it? Did that actually make a difference?
The New to Partnership programme ran from summer 2020 to summer 2023. And I think it's pretty clear that it did make a difference. The scheme cost the government around £51 million in total overall. It offered golden hello payments worth up to £20,000 to people taking on partnership roles in general practice for the first time, as well as some wider payments around that to support training. More than 2,800 GPs, plus just over 100 other staff, were awarded funding through the scheme to become partners for the first time. Obviously, some of them might well have become partners anyway, irrespective of whether or not there was an incentive scheme to support them into partnership roles. But if even half of those new partners were people who wouldn't otherwise have taken that step, then it's a factor that stopped the decline in partners being even steeper than it already was over recent years. And I think one question now is whether the sharp rise in younger partners leaving at this moment suggests that some of those people who came in through that New to Partnership scheme have perhaps now decided they've had enough. That's certainly possible.
You've mentioned uncertainty around neighbourhoods and those new neighbourhood contracts, which we're still waiting for. There's going to continue to be a lot of upheaval over the next couple of years, isn't there, including around the GP contract itself?
As we touched on earlier, going into a partnership role is a really big financial decision for a GP, which can involve taking on big mortgages, financial risk. And in that context, what GPs really need is as much certainty as possible. And in the current context, with a 10-year health plan playing out, the creation of neighbourhood contracts that could affect practice funding, as well as plans for a big overhaul of the GP contract within the current Parliament, things like the ongoing review of the Cahill funding formula, which shapes how practice funding is distributed, all that means there's a lot that's up in the air. And for a potential new partner, all that uncertainty might make them more likely just to hold off for now, see how the dust settles before they make a big jump into a partnership role. I think on the other hand too, existing partners might be wary of making big decisions like taking on new partners because of all the uncertainty. So that's probably another contributing factor to the drop in young partners that we're seeing.
Yeah, definitely. That's a good point, that. Just to mention to everyone listening that we've got a new video on our sister site, GP Business, this week, which is an interview with Robert McCartney, who is a lawyer at Hempsons. It's all about how neighbourhoods will affect general practice and the impact they could have on GP and primary care network contracts. It's well worth watching, and you can find that if you go to gpbusiness.co.uk. And as part of that discussion, we're also talking about what the future could hold for GP partnerships. So do go and have a look at that if you can.
On the last news podcast, we talked about how the jobs crisis is affecting GP registrars. And this week we've looked more specifically at how it's affecting international medical graduate GPs, because they've been hit particularly hard by this, haven't they?
Yeah, if you remember, 2 weeks ago we were talking about GP registrars who were delaying qualifying because there were no jobs available for them to go to. And I think we mentioned in that story that some of them were considering possibly moving abroad. Well, this week we've published another story by our senior reporter, Kimberly Hackett, about an international medical graduate, or IMG GP, who's basically been forced to move to Canada because he couldn't find a job. This is not just about the jobs crisis, it's also about the issue of visas for IMG GPs, IMG GP registrars in particular. So Kimberly spoke to Dr. Akram Hussain, who is the immediate past co-chair of the Royal College of GPs Registrars Group. So Dr. Hussain came to Scotland from India to undertake GP training. He received his exam results in May last year, and his official qualification date was August. So he started looking for work straight away. But after 7 months, he was unable to find a job with a practice who was a visa sponsor, and had to make what he described as a heartbreaking decision to move to Canada, where he was offered a job and all his visa issues sorted out. So this is a really good example of the impact of all of these issues. This is a really excellent young GP who's taken on leadership roles within the profession, who has lived and trained in the NHS, which has cost the NHS money, taxpayers' money to train him. And he has moved abroad, not because he wanted to, but because he felt there was no other option. He initially started looking for work in the west of Scotland, which is where he trained. But he was prepared to move to other parts of the UK, but he really struggled to find places that would offer visa sponsorship. He told Kimberly that even practices with IMG GP registrars were not set up to offer visa sponsorship to newly qualified GPs. So practices that did have visa sponsorships didn't have any vacancies. Practices who didn't have visa sponsorship did have vacancies. So he was really stuck, basically. And it's that reason why the jobs crisis is impacting on IMG GP registrars more severely, because there are very few jobs around anyway. And then if IMG registrars can only work for practices with visa sponsorship, then that leaves them with even fewer opportunities. And, we mustn't forget, currently around half of GP registrars are IMG doctors. So this is a major, major issue for these GP registrars and newly qualified GPs. And we're coming up to that period, in late spring, summer, where another big tranche of these doctors are due to qualify.
Yeah, as he said, it's a heartbreaking story for him personally, but it's also a story that ought to be ringing massive alarm bells for the NHS and for the whole recruitment programme, people who are involved in planning that and working out how we train and retain high quality GPs like him.
Absolutely.
Just in case people don't know, can you explain what the issue is around visas?
So anyone who comes to this country at the moment from a different place, they need to have lived here for 5 years before they can apply for what's called indefinite leave to remain. The problem for GP registrars is that GP training is only 3 years. So when they get to the end of their training, they need to have a job with an employer who is a visa sponsor to cover the next 2 years. The issue doesn't really affect any other specialty programmes because they are 5 years or longer. So by the time those doctors finish their training, they've already reached the point where they can apply for indefinite leave to remain. And also doctors from other specialties will usually be employed by hospitals or bigger organisations, and they're all visa sponsors anyway because they rely quite heavily on overseas workers. GP Online did an investigation back in early 2024 which found that the majority of GP practices were not visa sponsors. Results from a Freedom of Information request suggested that on average just 26% of practices in each ICB area were sponsors. And I think it's unlikely that figure's changed much since then, especially, because the jobs crisis means there are many more GPs looking for jobs than there are jobs available. So there's no real incentive for practices to become visa sponsors from that point of view. And also because many practices aren't recruiting anyway. But like, as you say, Nick, from Dr. Hussein's point of view, this is utterly heartbreaking. He wanted to stay here. He wanted to continue with his involvement in the RCGP. He saw himself taking on leadership roles in the NHS as well. He had all sorts of ambitions for his career in the NHS. He had friends here. He had a life here. And he's had to leave all that behind to start afresh somewhere else. And it really does just seem such a waste from the NHS's point of view as well, doesn't it? All that time that went into training Dr. Hussein, and then he can't even work here.
Canada isn't the only country that's targeting UK GPs, but it does seem to be somewhere that many GPs are considering, doesn't it?
Yes, I mean, well, lots of people are considering Canada, but obviously Australia is another country that GPs are leaving the UK for. Some Middle East countries really target UK-trained GPs as well. But Canada's been particularly aggressive in its marketing towards UK GPs. I mean, I myself somehow ended up on a mailing list for one of the recruitment firms that's trying to recruit UK-based GPs to work in Canada. I think they obviously thought I was a GP, and I got loads of emails trying to sell Canada and come to Canada. We really will value here. And I think that'll be familiar to most GPs listening to this. They're literally emailed daily almost from recruitment companies trying to get them to come and work in Canada or Australia or wherever. Canada's real shortage of GPs. And these jobs on offer are really attractive. Big salaries, much more than you'd get paid here. Lots of additional benefits as well. In particular, the main thing I think is guarantees that all your visa issues will be sorted out really quickly, that you can bring your spouse over as well, and that will all be sorted out for you. Dr. Hussein told Kimberly that the process of moving and sorting out the paperwork was really smooth. Australia's the same. They'll fast track registration, support visa sponsorship, provide additional support with relocation. So if you contrast that with the current system here, where even though these GPs have trained in the UK and uprooted themselves from another country to come and work here, they then struggle to get a visa to allow them to remain. I mean, it's not hard to see why many of these doctors feel that they are going to be more valued by countries like Canada and Australia than they are by this country. And, and given the rhetoric and issues relating to immigration affecting the UK at the minute, it seems highly unlikely that there's going to be any movement on resolving this issue from the government anytime soon. And I guess, even if there was, if nothing happens to resolve the jobs crisis, we'd like to see a big exodus of UK-trained GPs, whether they're IMG doctors or UK graduates anyway. The GP registrars we were talking about on the last podcast were weighing up Canada as an option, weren't they? But as I say, really this story about Dr. Hussein just shows that IMGs in particular are being really hard hit by this job shortage.
And the GMC actually raised the alarm about a growing exodus of overseas doctors, didn't it, last year?
Yeah, I mean, you actually wrote about this, didn't you? But this was from the annual GMC State of Medical Education and Practice Workforce report that was published in November. And that found that the number of non-UK qualified doctors who left medical practice in the UK in 2024 had risen by 26% when compared with the previous year. So this is an issue across the medical profession. In general practice specifically, the number that left the UK in 2024 was 27% higher than the previous year. That was 683 GPs. At the time that report came out, the GMC warned that this could leave huge holes in the NHS workforce. And that's the issue, isn't it? It's kind of like what you were saying earlier, Nick. We know that we're going to probably need more GPs in the future if we're moving towards a neighbourhood NHS. The reason GP training has expanded so much in recent years is because we had a shortage of GPs. And now, unless something happens to resolve the jobs crisis, we run the real risk of loads of GPs leaving the NHS, which will leave us completely ill-equipped to deliver on the government's plans to provide more care out of hospital. I mean, it really is a massive failure of workforce planning, and joined up thinking about how things like funding for the GP contract and rising inflation and what that meant for GP practices have impacted on the jobs available. If we're training more GPs, we need to make sure we have the jobs for them to go to. I mean, I suppose the other aspect of the story is probably worth mentioning here is the government planning legislation to prioritise UK medical graduates for specialty training places. Nick, you looked at that. What impact do you think that's going to have?
The impact for UK medical graduates should be that competition for training places is significantly reduced. This is something that's been a growing concern in recent years. The BMA voted last summer for UK graduates to be prioritised for specialty training. And we reported in September last year on a massive increase in competition for training places. For GPs, competition in 2025 hit the highest point in, I think, over a decade, with nearly 5 applications for every available post. Some other specialties had even higher competition ratios than that. there's some inflation of applications because doctors often apply for multiple specialty training posts. But ultimately, there are more applicants than places. And the decision the government has made is that UK graduates should be prioritised for both foundation and specialty training ahead of overseas doctors. For GP training places, NHS England says the competition ratio in the first round of applications will come down from around 3.4 appointable applicants per available post to just 1.1 once UK graduates are prioritised. So 1.1 to 1 means the vast majority of UK graduates who are deemed appointable candidates for UK GP training posts are likely to get one. The legislation could begin to take effect this year and then it'll kick in fully from 2027. But there are really big questions about the impact it's going to have on general practice. Currently, around half of GP registrars in England are international medical graduates. And the RCGP said that while it understood in the context of a shortage of places, there's a need to consider how to make sure public funding can be used best to build a sustainable workforce. This government and the last government have talked about building a sustainable domestic medical workforce. But at the same time, international medical graduate doctors make a huge and vital contribution to the UK health service. And the college and others have said that these changes have to be applied fairly and that the work overseas doctors do in the NHS must continue to be valued.
Moving on, another story that we're likely to see some developments on in the coming weeks relates to legal cases issued by physician associates or physician's assistants, as the recent government-backed review recommended they should be called. These cases are against GP practices, the RCGP and the BMA. Nick, can you explain what this is all about?
UMAPs, a union representing medical associate professionals, including PAs, said last week that it had launched a first wave of cases that will form part of a group action against GP practices, the RCGP and the BMA. Claims from 45 PAs will seek damages worth up to £7.5 million in total. And those claims could be heard in court, or at least an initial hearing from next month. And a further 70 cases are still being prepared, according to UMAPs. So this all relates to an ongoing debate over the role of PAs in general practice. Last year, the review you mentioned by Professor Gillian Leng, who's a former chief executive of NICE, found that instead of being called physician associates, PAs should be renamed physician assistants. And perhaps more importantly, it recommended that staff in those roles should no longer triage or see undifferentiated patients in general practice. And those findings broadly were in line with guidance that had come from the BMA and the RCGP over the sort of year leading up to that. They put out advice after high-profile patient safety incidents. Both the BMA and RCGP have also called for PA roles to be phased out completely in general practice. So what are the court cases about? Basically, when guidance came out recommending a significant change, so we are talking about the BMA and the RCGP guidance, and then also the Leng review findings, when all that advice came out recommending significant changes, limitations on PA roles, practices that employed them, mostly with funding from the Additional Roles Reimbursement Scheme, the ARRS, started making changes based on that guidance. The NHS originally advised practices that ARRS-funded PAs had to be allowed to see undifferentiated patients. So that was the way they were intended to be used. But when the BMA, the RCGP, and then the Leng review all said they shouldn't, practices that had used them in that way had to reconsider. UMAPs, however, disputes the advice about restricting the role of PAs, and these cases now are seeking damages from practices that employed them, plus in many cases the RCGP and or the BMA, because of the impact of their guidance and the contribution to PAs in some cases losing their jobs.
So UMAP says many cases have already been settled amicably. Do we know what that means?
We don't know the actual number of cases that have been settled amicably, but UMAP says many cases have ended that way, and in some cases that means payouts to PAs who may have lost their jobs or had a change in their role. And in other cases, it means that PAs have remained employed by a practice or another employer.
Have the BMA and RCGP said anything about this?
very little. The RCGP said it was aware of the legal action taking place, but that these are active proceedings, so it can't comment at the moment. And the BMA said something similar, that it couldn't comment at this time.
The other thing that's going on as well is that UMAPS is also seeking a judicial review to challenge the actual recommendations from the Leng review, isn't it? Do we know what's going on with that?
UMAPS kicked off this bid for a judicial review soon after the Leng review came out last year, so it's last June, I think. The judicial review names the Health and Social Care Secretary, it names NHS England, and then it now also names Professor Gillian Leng personally. She was added on sort of after the review. And it challenges the process, the outcome, and the legality of the Leng review recommendations. The union actually tried to secure an injunction to prevent any changes to PA roles until after a judicial review takes place. But the High Court actually rejected that claim last August. Despite that, UMAPS is saying it could take legal action against practices that make changes to PA roles while the judicial review is pending. And obviously, as we've discussed, dozens of cases have been launched at the start of this year, and there are potentially more to follow. Yeah, ultimately, I just think for the good of everyone concerned, whether we're talking about individual PAs whose jobs have changed, people who are still in their jobs, whether we're talking about practices, the BMA, RCGP, the health service as a whole, ultimately, if this judicial review is going to go ahead, it needs to come as soon as possible so that one way or another, a line can be drawn under this and people just know where they stand.
Before we go, we've just got time for our good news story, which this week is about the expansion of the government's WorkWell scheme. Following the success of a pilot in 15 areas, the scheme will be rolled out across all of England, backed by up to £259 million over the next 3 years. The scheme provides personalised early help for people struggling with their health that may prevent them from working, connecting them to local services such as physiotherapy, counselling and workplace adjustments. It's expected to reduce the need for GPs to write fit notes and reduce demand for GP appointments. The scheme will be available through ICBs working in partnership with local authorities, Job Centre Plus and community organisations to deliver locally designed services that meet community needs. So at a time when demand for GP services is at an all-time high, hopefully the scheme will help to alleviate some of that pressure. Well, that's it for this week. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.